ICM, the emergency medicine channel. Today we'll be discussing about an elderly gentleman who came to our ER with COPD exacerbation.
Okay.
A 78-year-old male patient was brought to ER with complaints of fever and breathlessness since last 2 days. Initial 10-second assessment, patient was conscious oriented and was able to complete one full sentence. Primary survey, his airway was
One
patent.
full sentence in normal voice.
No.
That definitely should be added.
Okay.
Not a husky voice. Okay, full sentence in normal voice. Good.
A primary survey, his airway was patent. There was no pooling of secretions, hoarseness, or stridor. His breathing, his respiratory rate was 24 per minute with a saturation of 91% in room air. Air entry was bilaterally.
When we tell about stridor, how do you differentiate when after examination? How do you differentiate a stridor from wheeze?
It is from the upper airway, sir. Stridor is from upper airway.
That's okay. Anatomically, it's from upper airway and the wheeze is from lower airway. How do you differentiate a stridor from wheeze?
It is usually inspiratory. Stridor is usually inspiratory.
It's not a must.
Inspiratory
It
and
can be-
or expiratory.
Stridor is classically defined as inspiratory and expiratory voice. What are the differentiating features of stridor from wheeze?
Then
It's a classical MBBS question. That's why I'm asking. We should know that. Because what happens is many patients who come with stridor to emergency room, unnecessarily doctors are giving nebulization. So we should avoid that. Stridor is always a fixed sound. So you ask the patient to cough, you ask the patient to sit, lie down, left, right. Every time you get same type of sound, and it classically occurs in both inspiration and expiration. It is a classical feature of stridor, and the change does not change. The quality of sound does not change at whatever you do. That will be fixed. That is the most important thing. It's because mainly it arises from the upper part. Wheeze is always polyphonic. That different character sound will come. Okay.
Breathing, his respiratory rate was 24 minutes. Saturation was 91% in room air. Air entry was bilaterally equal.
In a COPD patient, are you satisfied with 91% of saturation?
Yes, sir.
So we are satisfied.
We can keep a target between 88 to
In a normal
92%.
person, this is abnormal. In a normal person who does not have COPD, this 91 is very, very abnormal. But in COPD patient, this is acceptable range.
He had bilateral polyphonic wheeze, sir. His chest exertions, he was opening his mouth and breathing, and he was using his neck muscles and intercostal muscles for respiration.
Okay.
Circulation, his heart rate was 94 per minute. Blood pressure was 120 over 80 millimeters of mercury. All peripheral pulses were felt equally and bilaterally. Disability, his GCS was E4, V5, M6 and pupils were 2 millimeter bilaterally equal reactive. Exposure, his temperature was 100 degree Fahrenheit and GRBS was 106 milligram per deciliter.
Okay.
So, and hypothermia was prevented by
This
blank.
patient will be cyanosed. How do you know that this cyanosis is due to lung failure or heart failure? Patient can have cyanosis because of heart failure. Patient can have cyanosis because of lung failure. That means COPD, asthma and all. How do you differentiate?
Central sense.
Both will have central cyanosis. COPD will have central cyanosis. Cardiac failure will have central cyanosis. Cardiac failure, additional feature, they have peripheral cyanosis also.
Raised JVP, peripheral edema.
That all can be there in both.
Core.
One typical feature will differentiate clinically from cardiac failure and lung failure. What is that? Cardiac failure, what is the reason for cyanosis? It does not carry enough oxygenation and peripheral circulations are collapsed. Whereas in COPD, it carries blood to the peripheries but it contains more carbon dioxide. So what happened to the peripheral circulation in a COPD patient? What happened to the peripheral circulation in cardiac failure patient?
Peripheral circulation will be reduced in cardiac failure.
So if you feel the hand,
Cold.
it will be cold. Whereas you feel the hand of a COPD patient, it will be warm. So patient is cyanosed, warm peripheries, COPD with cyanosis. Patient is cyanosed, cold peripheries, mostly it is due to cardiac failure. Any cardiac failure, you can get a warm peripheries.
is due to the high
Thiamine
cardiac output.
thiamine deficiency and
Hyperdynamic state.
hyperdynamic state. Okay, that is only cardiac failure. You get probably warm peripheries. Okay.
Adjuncts to primary survey. At present, his airway is patent. He was tachypnic. So, and we were not knowing that he was a COPD patient. Sir.
Okay.
So, we started him on NRBM, and since he was having bilateral V's, we have started him on dual nebulization.
Okay.
So initially you told Strider also.
No Strider.
No
Strider.
Strider.
2 large bore IV cannulas were inserted, sir, and he was given injection hydrocortisone 100 milligram and magnesium sulfate 2 gram was given.
Okay. Is that a priority in this patient? Hydrocortisone is a priority in this patient.
No, so steroids usually will act slowly only. The effect will be coming slowly only, but it can prevent the recurrence. That is the only action.
Okay, steroids are not very useful in COPD at all, but it prevents long-term exacerbations. That's all. Short-term, it will not create any benefit, but whereas in asthma, it creates immediate benefit. Now, here it is not very useful. So, unless until you start an antibiotic to prevent infection, better to avoid steroids in case of COPD because that is not a priority. Okay, we have to give at one point of time, not in the early phases. Okay.
An injection paracetamol 1 gram was given since he was having fever, and arterial blood gas analysis was
How do fever reduces the oxygenation in a patient who is having COPD? Is it important to reduce the fever?
Yes, sir. Fever in turn can increase the respiratory rate, and
That's okay. What is the basic problem? If fever increases, what happens to your metabolism? It increases your metabolism. Oxygen demand is increasing. So patient's efforts are going to increase. So you control the fever. These are the conditions where you control the fever. Your patient is having respiratory failure, cardiac failure. All these conditions, your demand is increasing. So your metabolic activities are increasing. So you have to control the fever. Otherwise, patient will go to failure after some time. So better to control the fever immediately.
An arterial blood gas analysis was taken, which was showing a pH of 7.418.
7.4. Okay.
PCO2 was 52.5 and bicarbonate was 27 with a lactate of 1.4.
Okay.
PO2 was 60.4 and SO2 of 88.
What is your impression?
So it is a compensated respiratory acidosis.
Bicarb how much?
27.
Is it only compensation or something else is there?
Tachypnic. So
what is the pH?
pH is 7.418.
418. That means it has gone to the opposite side of the pH middle. 7.4 is the middle. 7.45 to 7.35. So 7.4 is the middle. So it has gone to the opposite side. Never a compensation will go to the opposite side. Compensation will be always towards the acidotic side, and it will come towards the center, not to the opposite side. If it has gone to the opposite side, there has to be an alkalosis. What will be the alkalosis here? What are the common?
Tachypnea.
Because of tachypnea.
Okay, that can produce some alkalosis.
Fever is there.
Okay, then what else will be there?
Lasix or something like drugs, we don't know what he's taking.
What is his potassium level?
Potassium level was 3.6, sir.
Okay, is it low or normal?
It is in the normal range, but low normal.
Towards, okay. In ABG it shows 3.6. Sometimes it will be low. So that is one of the common cause for additional alkalosis in a patient who is having respiratory disorder. Like you told, the patient can have additional respiratory alkalosis itself because of the tachypnea due to fever. Okay, but we have to always think that there is another problem because pH has gone to the opposite side. If potassium is really low, you have to correct it. Why should we correct potassium?
Because that potassium, if it is low, that for respiration and all, potassium is required.
Okay. Muscle activity, potassium is required. You have to correct it. Okay.
And if we are giving nebulization also, that will again cause shift hypokalemia.
Okay.
We have taken.
So never tell that it's a compensation. There is a compensation and something else is there. That we have to find out.
By that time, so now patient is started on NRBM and we are starting him on duolin nebulization.
Okay,
and
duolin is?
Duolin is ipratropium bromide with levosalbutamol is there.
Okay.
Then we also asked for an ECG, sir.
Okay.
ECG was showing normal sinus rhythm with the low voltage complexes was there, sir.
Low voltage complex diagnostic criteria.
QRS should be less than 5 millimeters in the limb lead and it should be less than 10 millimeters in the precordial lead,
Okay.
sir.
Okay.
There was no features of any P pulmonale, MAT or AF in the ECG, sir. Then ultrasound chest was done, sir. It was showing bilateral lung sliding.
What is a need of ultrasound chest in this patient?
Sir, it is a patient who came with breathlessness, sir. So we have to look for the lung sliding. We have to rule out any pneumothorax,
Pneumothorax,
and we have to look for effusion, B lines. And this patient is having low voltage complex, so we have to look for effusions, pericardial effusions, and everything. So bilateral lung sliding was present and bilateral B lines were present. There was no hepatization of the lung margins, no pleural effusion. Echo was showing good LV without any pericardial effusion. IVC was 1.2 centimeter collapse.
Okay.
Ample history, there is no allergies, no other past history or no non-medication. Patient gives a history that he was a smoker since the last 60 years, stopped 1 year back since he developed breathlessness, and from outside hospital he was told that he was having COPD, but he was not taking any nebulizations or treatment for that.
Okay.
His baseline NYHA score was 2, sir. Then
So there is another score, MRC scoring. Most of the doctors believe that will be useful for COPD patients. But NYHA is everybody know that NYHA scoring is that. MRC scoring, many doctors are not aware, but pulmonologists normally use MRC.
3 days back he developed cough with white sputum that time his breathlessness worsened and he was not able to do his routine activities, and 2 days back he developed fever with chills and rigor, and that time he was symptomatically treated with paracetamol and all, but his breathlessness worsened, and that's why he came here. Okay. There is no history of any chest pain, orthopnea, PND, or any history of any abdomen pain, headache, myalgia, or altered sensorium, sir. On head to foot examination, he was a thin individual. There was no pallor, icterus, clubbing cyanosis, lymphadenopathy, or peripheral edema. Upper respiratory tract was examined. There was no sinus tenderness. Then in the cyanosis was absent, sir. In the respiratory system examination, in the inspection, he was having a barrel-shaped chest, sir, but there was no supraclavicular hollowing or anything. He was using his intercostal muscles for respiration. There was no crowding of ribs, scarring, or any hollowing seen, sir. Palpation, inspiratory findings were confirmed, and auscultation, there was bilateral V's present, sir. Cardiovascular system examination, S1, S2 was heard normally. There was no loud P2 or any other features of cor pulmonale was checked, sir.
Loud P2 is a feature of
pulmonary hypertension.
Pulmonary hypertension. Cor pulmonale features are different. What are the features of cor pulmonale?
Features will be of left heart failure features.
Features of right
heart failure features.
What are the features?
Lower limb edema will be there. Tender hepatomegaly, raised JVP.
Okay. Can right heart failure lead to left heart failure? Yes. Okay. Bulging of the interventricular septum can produce ultimately it will produce features of left heart failure also.
For this patient, we have asked for a chest X-ray, sir. Chest X-ray was hyperlucent with a tubular heart, and diaphragm was pushed down with a wide and horizontal rib space, and there was no opacity.
What is the priority of chest X-rays in COPD exacerbation? Is it important or?
Just to rule out, we have to rule out a pneumothorax.
That is the most important. Pneumonia. So when we have a patient who is having breathlessness, chest X-ray is important for ruling out pneumothorax, but we have done an ultrasound here. It possibly rules out. Then pneumonia part, you can do an X-ray, but not a priority. You can wait for some time. Once the patient settles, you can take. Okay.
He was admitted, sir. So we have to categorize him according to the
Yes.
severity, sir. So in the ER, we have to triage according to the patient severity, sir.
Okay.
So we have to divide the COPD patients based on the absence of respiratory failure, presence of respiratory failure,
Yes.
presence of respiratory failure with life-threatening signs and without life-threatening signs.
Okay.
So this patient comes as a patient without any features of respiratory failure at present, sir.
You cannot tell like that. Clinically, you are not seeing, but ABG wise, you are seeing a
Seeing
respiratory failure which is compensated. So
Compensated.
he is in respiratory failure, but he is compensated for
Compensating
that.
for
His body is compensated for that. Okay.
So, and we have to check for the other scoring. As we look for the CURB 65, we have a BAP 65 score.
Okay.
That means we will be looking for the blood urea nitrogen, that if it is more than 25, and we will be looking whether the patient is having altered sensorium, and we will be looking the pulse rate. If the pulse rate is more than 110 and if the age is more than 65, then according to the increase in score, we have to categorize the patient and plan to shift him to ICU.
Why the patient should have altered behavior in COPD?
Carbon dioxide
Narcosis.
narcosis.
Okay. Carbon dioxide increases more than certain level, he can have altered behavior. Even hypoxia can also produce altered behavior.
So this patient was admitted to the HDO area, sir, and he was started on nebulizations. Beta 2 agonist nebulization was started, sir.
Which will be more useful in this patient, beta 2 nebulization or other like you told ipratropium, tiotropium.
Usually beta agonist will be usually acting on the larger airways, sir, and this ipratropium and all will be acting on smaller airways. So ipravent is ideally choice
that is the best choice, but we always combine
both.
because both lesions will be there, but this will be predominantly small airway disease. So ipratropium is the ideal drug to be used, but we add levosalbutamol to that.
Yes, sir. Then we have to, depending on the patient's improvement with the nebulization, we have to adjust
How
the
many
frequency.
nebulizations you normally give?
Usually we have to give 3 nebulization, then after that we have to reassess after 20 minutes.
So
Then we have
one of the common problem of nebulizations, when you give like this, what are the problems patient can tell?
patient will be having tachycardia, palpitations will be there, tremors will be there, then shift hypokalemia can
So
be there.
how do they present? The clinical presentation of hypokalemia.
They will
What
be
the patient will
fatigue will
Muscle
be
cramps. Muscle cramps are the most important side effect most of the patient tell. After 2-3 nebulization, they have severe muscle cramps. So we should take care of that. Hypokalemia is a cause.
Then along with that we have to consider antibiotics, sir. Antibiotics also depending on the patient's presentation. If the patient is presenting with fever or features of pneumonia and all, we have to consider antibiotics.
Normally most of the exacerbation in COPD are due to infection. So even if we don't have clinical findings of infection, better to treat. Why it is like that?
Because they are already having a progressive disease with a damaged airways.
Okay.
So
There is
the
a protective mechanism for most of the human being. So we get a aspiration or infection, body try to remove that. Okay, ciliary action will remove that. But in COPD, that ciliary action is lost. So whatever gone inside is inside only. That create problem. So better to treat this patient with antibiotic. Like what are the organisms which can produce infections in COPD?
gram positive organism, mostly streptococcus, that is seen in.
Okay, normally like any other patient, you can get viral infections, protein, streptococcus, all these things.
Then H influenza can be there,
And
moraxilla can be.
So normal lungs mainly affect with gram positive infections, but an abnormal lung always you should consider gram negative. So that type of antibiotic you should start. Don't start a antibiotic which covers only gram positive.
Then in patients, if we are suspecting a pseudomonal infection, that means a patient.
How do you suspect pseudomonal infection?
That means if the patient is immunocompromised, there was a history.
Immunocompromised. But what else?
Previous hospital stay.
Previous repeated hospital stay and or bronchiectatic lesions. Like that, if multiple hospital admissions, previous infections, previous culture report, then you have to suspect pseudomonas. Otherwise, routinely we don't suspect pseudomonas.
In such cases, we have to treat with start with piperacillin tazobactam. Sir.
Okay.
Other cases, we can give either gram-positive coverage with levofloxacin or ceftriaxone can be started. Sir.
Levofloxacin or moxifloxacin is the ideal drug. Ceftriaxone, if you are starting, you have to give additional gram-positive coverage like augmentin or something. Okay. Ceftriaxone does not have major gram-positive coverage. It has got good gram-negative, some gram-positive, but in a major infection that may not cover. So you have to add a gram-positive coverage. If you are starting piperacillin tazobactam, everything will be covered.
Then antivirals, depending on the condition, we have to give. Sir.
Okay.
Then indications for NIV and intubation.
Okay.
So depending, first we will tell when all we have to give oxygen. Sir.
Okay.
If the PaO2 is coming less than 60, in that cases only we will have to give oxygen, because COPD patients usually hypoxia is the respiratory drive for them. So unnecessarily we are not supposed to give oxygen. Sir.
Okay. Unnecessary, it is not, we are not supposed to give, that is wrong. We are not supposed to give high flow oxygen. Normally, COPD patient requires small amount, that we'll discuss afterwards.
Then indications of NIV is the patient is having a respiratory acidosis with a pH less than 7.35 with the respiratory rate more than 25. We can start on NIV, provided that the patient is able to protect airway and is able to bring out the secretion and will not aspirate. So in such cases we can start NIV, and after 1 hour we can check the HACCOR scoring. That means we will be looking the pH, ABG pH, the respiratory rate, the GCS of the patient, PO to FiO2 ratio of the patient, and depending on that we will decide whether the patient is going for a NIV failure or NIV is okay for that patient. So if the HACCOR score is coming more than 5, then we will have to decide on intubation.
It is very important. After how to give drugs and all.
So intubation.
So what is the main advantage apart from the carbon dioxide was out by CPAP or non-invasive ventilation?
Work of
Work of
breathing will be
Of breathing, the expenditure of
energy.
energy, reducing the metabolism and the oxygen demand. Okay, that's another advantage you have to keep it. So when and how will you decide to go for an intubation and mechanical ventilation? At what stage will you decide?
If the patient is already on an NIV, when the patient is going for an NIV failure, or the patient is having very low sensorium, if the patient is in carbon dioxide narcosis, inability to protect the airway, or if there is a high risk of aspiration and all, we will have to plan on intubation. Sir.
Ventilatory excursions. So over a period of time there will be fatigue of all the respiratory muscles. So you need not have to wait till the patient goes for apnea. So before that you should be able to well in advance make a diagnosis. He needs the intubation and ventilation. Okay, in the COPD patients, what are all the important points you have to keep in mind regarding the not only drug selection, other aspects of ventilation?
Yes, sir. We have to go for a lung protective ventilation, sir. That means we will have to target a low tidal volume for these patients, because COPD patients might be having some bullae and all that might get ruptured. And if we are giving
low tidal volume means how much volume?
6 to 8 ml per kg. Normally we will be keeping 8 to 10 ml per kg, sir. And
are you using low tidal volume in any other
ARDS ventilation?
Okay.
There, what is the reason?
There, because the normal lungs, that means if you are giving high pressures and all, the normal lungs can get injured.
Here we are thinking about bullae which can rupture. There, lung cavities are already filled with some amount of fluid, so resistance. So if you give more pressure, means there can be pneumothorax. Here also pneumothorax occurs. That's it.
Then we will be keeping a low respiratory rate, sir, because in these patients there will be air trapping, COPD patients. So we will be, if we increase the respiratory rate, what will happen is the carbon dioxide washout will not be possible. So we will be reducing the respiratory rate. We will be increasing the IS to E ratio, so that the expiratory time will be more, so that the carbon dioxide can be brought out, sir. And for drug selection also, we have to select the drugs. If we are planning for a delayed sequence intubation and all, we have to reduce the drugs which can cause sedation.
What is the advantage of delayed sequence intubation in this patient?
If we can keep a positive pressure ventilation with the low dose of like ketamine and all in the half dose can be kept, so that we can attain that oxygenation for the patient, and then we can intubate. And induction agent, we can select ketamine also. Ketamine is having a bronchodilatory property, and it will not be suppressing the respiratory drive. So ketamine can be selected, or propofol can be selected.
What is the disadvantage of ketamine in such cases?
Tachycardia and hemodynamic. If the patient is having some pulmonary or associated cardiac abnormalities, that can affect the heart.
This patient have a lot of secretions. So this will further increase. So along with glycopyrrolate, we can use it. Okay, good.
Okay.
Induction.
Glycopyrrolate, sir was telling, that's why I'm asking.
Propofol.
Anything we are giving which can mimic glycopyrrolate in this patient?
So
Ipratropium bromide has got almost similar effect, but we are, like sir told, we can, glycopyrrolate has got a better action.
Okay. These for intubation, these are things. Then if we are keeping a very high tidal volume, what can happen?
Analgesic part, most important thing. See, already the any severe bronchospasm occurs because of the triggering action, vagal stimulation. So we have to use fentanyl. Okay, so other agents we can avoid, especially morphine, long-acting drugs. Even midazolam may cause respiratory depression. Even so, better choice is propofol or ketamine. Ketamine is having an analgesic property. We are using propofol, we can combine with fentanyl. What is available here?
Okay. What are the other drugs you have told about nebulization? What else you told? And steroid we can give. Then antibiotic. Then other drugs.
Magnesium sulfate can be given, sir. Then mucolytic drugs. We have the short-acting beta agonists, long-acting beta agonists.
One of the common mistake done by doctors are they give antihistamines for this patient. Do you recommend antihistamines? Or anywhere you have read antihistamines?
That can again increase the sedation.
Antihistamines should not be used in a patient. Acute exacerbation of both asthma and COPD. What it will do to the lung? Antihistamines are used for long-term prophylaxis, not short-term. In hospital, try to avoid antihistamines if possible. Why you want to avoid? It will dry the secretions. If you dry the secretion, again the problem will be same. Like it will become the lung, bronchioles will collapse. Okay, so we should better avoid antihistamines in this type of patients.
For this reason, see, we have to humidify. And humidified oxygen is better. Okay, you don't use it dry it, because when the secretions are moist and liquid, we can able to suck it out. So it is once dried, it will be forming a incrustation in the smaller passages, and it will cause block also.
Okay, so this patient will be admitted to your ICU. How do you proceed?
Yes, we have to give bronchodilator therapy, antibiotic therapy, and oxygen we have to titrate, so that we have to maintain a saturation between 88 to 92%.
What is LTOT?
LTOT is long-term oxygen therapy, sir.
What is the advantage?
Advantage is that in patients with COPD, that means if at all their PaO2 less than 55, or if the PaO2 is between 55 to 60 with features of pulmonary cyanosis and all, we will be giving long-term oxygen therapy.
How do it improve the patient?
Pulmonary
dilatation features will be there.
It will not dilate the pulmonary artery. It will prevent the endothelial damage or endothelium. There will be increased number of cells in endothelium once there is low oxygen. So that will be arrested. Okay, whatever is the patient now, it will remain. It may not improve because already endothelial damage has occurred. The pulmonary arteries have become smaller in its size. So it may prevent that further pulmonary hypertension can be prevented by oxygen. So how much time you have to give oxygen? What is the percentage of oxygen?
We have to give at least for 16 hours, but we have to give very low. That means maximum 2 to 4 liters per
2 liters are ideal for 16 hours should be given. Okay, what else you should advise the patient?
Advise the
On
patient,
discharge.
discharge we have to smoking cessation,
Okay, that is
should
very
be.
important.
Then vaccination.
Vaccination for
For influenza and pneumococcal
pneumococcal.
vaccination. Then low carbohydrate and high
low
protein
carbohydrate
diet.
diet, then high protein
Protein
diet,
diet
then
should be advised.
potassium
Potassium
supplementation.
supplementation should
Then
be corrected.
and
Then
you have to
vitamin D.
vitamin D should be given for improving the lung
Modulation.
Okay,
Then we can give azithromycin prophylaxis can be given, sir. 250 milligram alternate days can be given. Sir.
Okay,
Then for routine nebulization, we MDAs can be given,
okay.
sir.
So patient may ask you which is better, whether tablets, nebulization, rotacaps, MDIs, which is better? Tablets are not superior at all because we are giving higher amount of tablet, but here we are giving only micrograms. In that, which is better, nebulization, rotacaps, or MDIs?
All are equal, sir.
All are equal in efficacy. So no need to worry what you are giving. All will have same effect. But some patients, because of COPD and all, nebulization will be easy. Or they are not putting any effort. But other one, they have to put effort. Okay. What nebulization or MDA you will advise for this patient?
Formoterol, fluticasone,
budesonide. That is a combination. Why formoterol?
Because it is a long-acting beta agonist, but it can help in acute exacerbation.
It's a rescue drug. It's a preventive drug. Whereas you give salbutamol, you have to give salmeterol to prevent. If you are giving salmeterol, you have to give salbutamol to have a acute attack. So better to give formoterol with budesonide. Okay. So that should be advised for the patient. What else? Anything else you want to advise a patient?
Correct method of using
is very important.
Then other comorbidities and
anything else you want to advise the patient? Physiotherapy. What physiotherapy you advise? Incentive spirometer. What is the advantage of that?
It increases the functional capacity.
Okay, it increases the functional capacity of the lungs. Okay, you try to do that every day. Your lung capacity will increase. Okay, why lung capacity should be increased? Lung is already there here. Lung is actually expanded here. What is the problem in COPD?
The clearance of the secretions.
How do it improve with your spirometry? Lung is expanded. You have seen the X-ray. It's totally expanded. Normally, you see the physiology of your lung. You take a deep inspiration. Your body is trying to take a deep breath inside. Then what happens?
Body will try to push it.
Body will, if once you stop breathing, automatically you expirate. When you are expirating, there will be elastic recoiling of your lungs. In COPD, what is happening? You are taking a breath with your effort, but when you are expiring, that elasticity is gone. So there is no expulsion. The lung is not pumping the air out. Whatever you are taken inside, that is remaining there. So there is no further air can come inside. It's not going out. It's only present trapped inside. That air trapping is a problem in COPD. So we have to train for that. Air trapping, you should train. You should train them for inspiration and expiration, and sometimes you have to train for pulse sleep breathing. That's a auto PEEP
method.
Because it's not held there. It is going in and out without any control. Because lung is not collapsing completely. So that problem should be avoided. So we have to train them properly, either with incentive spirometry or a lung physiotherapist can train them for pulse sleep breathing, all these things. So that requires special training. Otherwise, this patient will never improve. Okay. Anything else, sir?
See, how will you administer low FiO2 oxygen? Which mask you use, sir?
We can use nasal prong, sir, or Venturi mask can be used, sir.
Nasal prongs or nasal canal, that is enough. See, it's for a prolonged period. Keeping a mask over that, he cannot able to do activities in between. You have to disconnect and do it. Okay,
can you use oxygen generator in this patient at home? Oxygen generator is nothing but it generates oxygen from the room air. Okay, so instead of using a cylinder concentrator, you can use oxygen generator. Some oxygen generators produce oxygen up to 15 liters, but most of the oxygen generators produce oxygen up to 4 or 5 liters. That will be enough for a patient. because oxygen, if we are prescribing oxygen, cylinder will be very costly. That also should be kept in mind. Cost of the treatment is very important.
Plus now the corona
You may not get.
serving case you use oxygen.
So better to if patient requires long-term oxygen concentrators or generators are more useful at home. Anything else?
Okay, sir.
Okay.
Good.
Thank you.
Thank you.